Dr. Wunderlich, Dr. Snell, and members of the committee and the audience, thank you for your time and attention today. My name is Tony Calkins, and I'm going to present my quality improvement project about improving patients' self-management of heart failure. This project was conducted in the northeastern United States within an academic institution. I'd like to give a formal thank you to Dr. Rita Wunderlich for the time and energy spent with me working on this project. Additionally, I'd like to thank the other committee members, including Dr. Kearns and Drs. Lauren Meese, who is the appointed community representative for my project. For a successful treatment plan, patients will require a clear and concise follow-up schedule, as well as close communication with a heart failure specialist, either at the time of discharge from the hospital or within outpatient visits. With close follow-up after a heart failure-related hospital discharge being so important, there needs to be a semi-predictable plan for each patient. A project such as this will serve to ensure that more patients receive adequate outpatient care, titrate their GDMT at an appropriate time frame, and reduce the burden of hospital readmissions. It is well known that medical therapies for heart failure are assisting in keeping HFrEF patients free of and delaying the time between acute exacerbations, hospitalizations, and requirement for advanced therapies such as intravenous inotropes, left ventricular assist device implantation, or heart transplantation. Maximum efforts must be made to ensure that patients discharged from the hospital with a diagnosis of congestive heart failure are promptly and appropriately managed. Helping arm patients with the knowledge of how to manage their disease process needs to be an essential component to hospital discharge facilitation. The most important steps to ensuring that patients are on guideline-directed medical therapies occur well after an acute decompensation has been remedied and rely on a strong discharge facilitation effort and close follow-up outpatient. One of the most important components of treating and managing heart failure is care after discharge outside of the hospital. According to Driscoll et al., some common barriers related to the appropriate prescribing and titration of heart failure therapies include lack of appropriate follow-up, lack of experience in treating heart failure, and titrating medications such as beta-adrenergic blockers and angiotensin-converting enzyme inhibitors. The survival rate of patients with chronic heart failure problems has improved dramatically as medical therapies have become proven and readily available. GDMT currently includes the likes of renin-angiotensin-aldosterone system inhibition and neurohormonal blockade efforts in order to reduce the negative physiologic response to heart failure. With a population that continues to grow and a life expectancy that rises as medicine evolves, patient-focused education strategies will potentially become a necessity to practice. Creating strategies for providers to help patients adhere to clinical guidelines is an important practice. This project serves to demonstrate that improving patient education efforts at the time of discharge from the hospital will reduce 30-day readmission rates for heart failure patients. This literature review serves to demonstrate the importance of patient self-management of heart failure after hospital discharge. The question of inquiry is, in adult patients that have heart failure with a reduced ejection fraction less than 40%, how effective would providing AHA, American Heart Association approved information regarding the self-management of heart failure at the time of hospital discharge be in preventing 30-day hospital readmissions with a heart failure-related diagnosis? This scope of this review will remain limited to published and peer-reviewed works only. Throughout this review, primary research articles have been utilized to demonstrate that there is great need for improvement in reducing 30-day heart failure-related hospital readmission rates. There are common themes among the chosen articles that tie the literature together and include but are not limited to improvements in mortality rates, benefits to practice, and advantages to change. The majority of the articles selected utilize prospective and retrospective data in order to determine the efficacy of the observed interventions. I will briefly discuss the weaknesses, gaps, and limitations identified in the available literature. For weaknesses, one apparent weakness identified throughout this literature review was a lack of data geared towards primary care providers and general practitioners managing heart failure patients post-discharge. Patients should not only have to rely on a specialty service to help manage medications for an incredibly common disease process. Alongside a heart failure specialist, a multidisciplinary approach can be done safely and should include several types of providers. Driscoll et al. Utilized a small sample of 28 patients, but included an appropriate observation timeframe of 6 months. The study performed by Ajam et al. Collected retrospective data and were unable to reliably identify that every participant within the study had a low enough ejection fraction to meet the inclusion criteria. Some identified gaps. The studies utilized have revealed the need for more primary care providers to be utilized in ensuring that heart failure patients receive appropriate post-discharge care and management. Lack of experience and uncertainty from providers and nurses has been noted in multiple studies as being an important area of improvement. Goldgrab et al. Identified ongoing disparities in patient education and self-management abilities resulting in non-adherence to medical therapies. There needs to be ongoing effort related to assisting patients in understanding their heart failure diagnosis and adhering to the guideline-directed treatment plans. As for limitations, the design themselves did not have any glaring limitations. This type of project and study is heavily limited by the patients and resources available to them. Due to adherence rates and the medication tolerance being an individualized problem, not all patients can be expected to have the same ability to appropriately follow up as outpatient. Future studies should include a clear rationale of why patients had a 30-day hospital readmission in order to identify the major barriers during the study. These observational studies are also limited by the patient's adherence to recommendations and follow-up appointments. Conceptual models and theoretical frameworks assist in identifying relationships and thought processes between research studies and help to connect related ideas. Lippitt's model of change provides a theory that involves reviewing current practice methods, unfreezing the methodologies while creating improved modalities and refreezing them into new practice. This model was created after utilizing Lewin's change theory, which discusses unfreezing current practice methods, creating improved models, and then freezing them back into practice as a new operating procedure. The aforementioned model of change involves 7 different steps that include A. Develop need for change by diagnosing change. B. Establish change relationship and assess the motivation and capacity for change. C. Clarify assessment for change and determine resources. D. Establish goals and intentions for an action plan. E. Examine alternatives. F. Transform intentions into actual change and maintain the change. G. Generalize and stabilize change and end the helping relationship of the change agent. This theory ties directly to this DNP project as there is group consensus that patients are being readmitted far too frequently. With current practice, patient management efforts are typically managed by a heart failure specialist and done through regularly scheduled clinic visits, oftentimes every 2 weeks. Patients are often tasked with recording their blood pressure and heart rate, obtaining scheduled lab work, and faithfully attending routine follow-up visits and telephone calls in order to safely and successfully up-titrate their therapies. Large barriers surround current methods of outpatient management strategies include problems such as side effects of the medications, inability to attend regular follow-up visits, and prohibitive costs to the patient for clinic visits and medications. With the assistance of Lippitt's theoretical framework, this DNP project will demonstrate that current methods for educating heart failure patients is ineffective and that alternative methods have proven to help more patients achieve better outpatient outcomes. So to break all of this down, Lippitt's theoretical framework model of change diagnosed the need for change and established a motive for change. A change in clinical practices prompted by the high frequency of 30-day hospital readmissions. Clarify assessment for change and establish goals for an action plan. Education of evidence-based risk factors, monitoring patient rationale for poor outpatient follow-up and/or adherence. Examine alternatives, transform intentions into actual change, and stabilize the change. So we must determine the efficacy of our current interventions and visualize improved outpatient follow-up as well as a reduction in heart failure readmissions. The purpose of this quality improvement project is to determine if the addition of face-to-face education using the American Heart Association approved handout for self-management of heart failure on the patient's day of hospital discharge will reduce readmissions for patients with heart failure post as compared to pre-intervention standard of care. Pre-intervention standard of care is only a 48-hour post-discharge follow-up phone call. The author is the sole provider to conduct phone calls to patients with heart failure 48 hours post-discharge. By adding the face-to-face interaction, the author aims to provide a more extensive education to self-manage heart failure symptoms using the AHA handout and improve patient outcomes. It was originally anticipated that 154 EMRs would be utilized for the purpose of this study, but only 60 total were accessed. For the design of this project, it was a quality improvement project, including educational intervention alongside 48-hour follow-up phone call. There was a 31-day data collection period per subject. This was a retrospective observational study. All subjects were de-identified to protect their information. The setting, an inpatient unit providing advanced heart failure care. This was in the southeastern United States at an academic center. Our inpatient heart failure service discharges roughly 1,500 patients per year, so we're pretty busy. And for our sample, I used a convenience sample, patients 18 years of age or older, and the ethnicity overall 75% Caucasian and 25% from other ethnic backgrounds. This DNP project utilized a data collection sheet created on Excel by the principal investigator. The data collection sheet is comprised of de-identified subject data that includes if the intervention was used, if the subject was contacted within 48 hours of hospital discharge, if the subject was able to verbalize their next follow-up appointment, and if the subject was readmitted to the hospital for heart failure complications within 30 days of discharge. Data abstracted from EMRs were from patients who were discharged from the hospital's heart failure service during the pre-intervention time frame of July 1st, 2020 through September 30th, 2020, or during the post-intervention time frame of October 1st, 2020 through December 31st, 2020. Some of the key criteria to meet inclusion to this study were having an EMR documentation of the following. The subject is 18 to 89 years of age. The subject was discharged from the heart failure service, and the subject has a diagnosis of heart failure with a reduced ejection fraction less than 40%. The principal investigator was the only staff member, and there were no expected needs for additional staffing for this project. This project was done at the facility where the principal investigator is employed. All physical and material needs were met by the facility that the project took place in. There were no anticipated travel, material, or personnel costs to this quality improvement project. Pictured here is the data collection tool that was utilized for this project. The absolute minimum necessary data to accomplish the goals for the project were collected and stored on this sheet. All potential patient identifiers were removed and not collected for this project. There were no foreseeable risks to subjects in this retrospective medical chart review beyond the potential risk of breach of confidentiality. To reduce those risks, these medical records were given a number and all potential identifiers were removed. The collection sheet was stored in the author's locked office on a password-protected computer. Access to the password in the office were limited to the author only. All information presented was without identifiers and in aggregate form. All of this data will be destroyed 3 years after the completion of this project. For the data analysis plan, data was quantitative and transcribed using the data collection sheet as previously shown. This project utilized quantitative data to compare readmission ratios directionally, meaning that one value should be greater than the other. Analysis of data utilizes z-test for the difference of two proportions. The z-test compares the mean of two sample populations when there is a known population variance alongside an appropriate population variance. There was no data collection in terms of descriptive statistics such as age or gender utilized in this data analysis. Data were abstracted from EMRs of patients 18 years to 89 years old in a population comprised of approximately 75% Caucasian and 25% from other ethnic groups, and all genders were included in this data collection process. A total of 60 patients' EMRs met the inclusion criteria. Initially, 30 EMRs were analyzed to retrieve post-intervention 30-day hospital readmission rates during the post-intervention period from October 1st, 2020 through December 31st, 2020. Also, 30 EMRs were analyzed to retrieve pre-intervention 30-day heart failure-related hospital readmissions of patients who received no educational intervention from August 1st, 2020 through September 31st, 2020. Pre- and post-intervention data were collected and analyzed using numerical data and a chi-square and/or z-test. The pre- and post-intervention data included a documented 48-hour follow-up phone call, scheduled follow-up appointment, and 30-day readmission. The data collection sheet recorded that the EMR documented a 1 for yes, a 2 for no, and 3 for non-applicable in relation to the measured observations of 48-hour phone call, scheduled follow-up appointment, and 30-day readmissions. So, as for results, this DNP project was able to successfully establish a clear improvement in 30-day hospital readmission rates after providing an educational intervention to patients at the time of hospital discharge with a diagnosis of heart failure. Additionally, it was noted that more follow-up phone calls were documented with the post-intervention group. The addition of ensuring subjects had a scheduled follow-up appointment yielded insufficient information to suggest an increase in the ratio between pre and post-intervention. This project did not have any very abnormal limitations. In the end, it was decided that this project was limited by the small convenience sample and short data collection period, as well as inadequate data for statistical analysis to identify relationships between risk factors, and changes in the study context, including length of stay, visitor policies, and unit changes related to COVID-19, including education and staffing. As healthcare providers, it's our responsibility to find ways to best serve the patient populations that we treat. When patients understand the care plan and why we institute things like lifestyle restrictions, they are much more likely to adhere to the plan. More care plan adherence is almost guaranteed to result in more positive patient outcomes. The outcome of this DNP project supports the amount of help heart failure patients require in managing their disease. Hospital administrators are already well aware that when a heart failure patient is discharged from the acute inpatient setting, there is a high likelihood that they will be back within 30 days for either an emergency room visit or readmission. This quality improvement project has helped to guide patients with disease management strategies and has likely been able to develop a better foundation of autonomy for patients so that they no longer feel as helpless at home when managing their heart failure. Through this DNP project and the data collected, there should be few barriers from the administrative side of an organization in order to suggest changing the way discharge planning is completed. Heart failure is a disease affecting more than 6.5 million Americans, and more than 1 million of them will be hospitalized. Studies have continued to prove that heart failure patients require a multidisciplinary approach and that single interventions will not be effective often enough. Patients equipped with better self-management strategies can help to reduce the burden of need from healthcare providers, as well as the need for patients to follow up in clinic so frequently, especially during times of clinical staffing shortage. This project was able to collect and analyze clinically significant data. Education efforts remain to be a mainstay in helping patients manage their acute and chronic illnesses. During a hospitalization, you can have a patient and their family members' undivided attention, making the inpatient hospital setting desirable for educational efforts. When a patient is recovering from a heart failure exacerbation and able to rest comfortably, teaching for them and their families needs to begin. Multiple teaching sessions should allow for teach back towards the end of the hospitalization, and you can measure just how well the information was received. Implications of research. The educational intervention was developed to assist patients at the end of a potentially critical hospitalization in better understanding the disease of heart failure and how to best manage at home from the outpatient standpoint. The results from this project have demonstrated that educational understanding of disease is of utmost importance, and that understanding can help lead to better symptom control and, most importantly, a reduction in 30-day hospital readmissions. Creating a more standardized approach for ensuring that patients are better prepared to manage the diagnosis of heart failure has been consistently proven to be a critical need. For nursing practice, better self-management should lead to a reduction in utilizable healthcare services. The educational intervention can be given by both bedside nurses and providers. For further research, the educational session can lead to identifying gaps in disease understanding. Patients must be continually tracked after discharge to guide and manage their heart failure. And teaching regarding the self-management of heart failure needs to occur at numerous stages on patient management, both inside and outside of the hospital. Some conclusions to tie everything together. Empowering patients to self-manage their comorbidities has the ability to improve hospital readmission rates. This project demonstrated that educational interventions can modify outpatient care. Discharge facilitation and planning remains to be of utmost importance for patients leaving the hospital with a diagnosis of heart failure. And improving patients' abilities to self-manage heart failure has the possibility of reducing mortality and morbidity. I will end this presentation with a thoughtful quote that perfectly sums this project up. As demonstrated by the research, each patient requires an individualized plan for facilitating a successful transition from the hospital to home and preventing readmissions. Therefore, it is essential to review the patient's current plan of care and adherence to it, looking for clues to failure of the plan that led to readmission to the hospital. And with that, I would like to thank everyone in attendance for listening to my presentation.